Good morning and welcome to the Orlando Live Endoscopy webinar sponsored by Medtronic. I hope you had spent some time this morning viewing the breakfast sessions, and we are now going to transition to live endoscopy demonstrations. We will be performing three procedures. One will be a radiofrequency ablation of Barrett's esophagus. The second will be sampling of a pancreatic mass and placement of fiducials in a suspected pancreatic cancer. And the last case will be a live transmission from Winthrop Hospital in Long Island, New York, by Dr. Stavros Stavropoulos. This will be an endoscopic submucosal dissection using the new Medtronic ProDGI traction device. I hope you had a productive time this morning, and I hope you will enjoy the rest of the session today. I want to thank particularly Dr. Irving Waxman from the University of Chicago and Dr. Stavros Stavropoulos from Winthrop Hospital for being guest faculty and for participating in this webinar. Thank you.
Okay, well, good morning and welcome everybody to this live webinar. I'm Rob Hawes behind the mask, and I'm delighted to be with you today. This is an 80-year-old gentleman who has a very interesting history. For many years, he had very serious problems with heartburn. And then maybe about 20 years ago, 15 years ago, the heartburn went away, and he's had no problems whatsoever. And this is a very typical history for patients with Barrett's esophagus. He never got endoscoped until this year, and the endoscopy was done, showed Barrett's esophagus, biopsies were taken, and they were confirmed to be low-grade dysplasia. So he's been referred for consideration of radiofrequency ablation. I talked to him prior to the procedure, and we talked about the algorithms for management. I talked to him about the rationale for treating low-grade dysplasia and answered all his questions. And so we're proceeding now to examine the esophagus and with the intent of treating his low-grade dysplasia. So as I mentioned in my talk, I have a high-definition endoscope, and I have a cap fitted on the end of it. You can see the cap here. It's an Olympus cap, and allows me to focus well on the mucosa. Here is a retroflex view in the stomach. And you can see here really not too much of a hiatal hernia, which is unusual. I think most of these patients have a fairly big hiatal hernia. So I'm going to straighten back up now. And now I'm entering the Barrett's segment here. And you can see the Barrett's segment here. You can see here in the upper right-hand corner, there's a squamous epithelialization. This is likely a biopsy point. So this segment of the Barrett's has been biopsied here. Come back. There's another squamous island here, which again is likely a biopsy spot. You can see here, at least my first impression is that at least this lower segment, I wouldn't consider it nodular, but I do consider it a little bit more sort of lumpy bumpy, if you will. Not lumpy bumpy is not the right word, but a little bit more mildly irregular than sometimes we see. But if I inflate the esophagus well there, you can see that it's really reasonably flat, at least in this lower segment. And then I come back up, and the GE junction I estimated is about right here, and that looks like it's at about 46 centimeters from the incisors. I come back up now, and here's this lower segment. It's circumferential, at least at this point. And I'll come back up to where the squamous epithelium starts. And this is at about 43. So from 46 to 43 is circumferential Barrett's. So I'm looking around here. Now there is a mild nodule there, so we have to be a little bit cognizant of that. And then I come back up here, and now I'm a little bit more concerned. I think this, Dr. Bang, I think you would agree with me, this is more than just a minor sort of little bit of elevation here. I think that's more than a minor elevation. I'll come back further here.
Yes, I think so.
And there's clearly a nodule here, okay? That's clearly a nodule there. And then we've been looking at this area here at about 3 o'clock. And this also, to me, is at a minimum sort of thickened. It's not markedly nodular, but at least is a little bit thickened there. And then we've got these tongues up here, at least this tongue at about 11 o'clock, which looks more smooth. So a little bit of variable, I think, topography, if you will, in this particular patient. Dr. Bang and I spent some time sort of looking at this distal segment, and you can see here that at least by NBI, and then I'll use a near focus mode, it's sort of a funky mucosal and vascular pattern. I take a little bit of comfort in that this biopsy here was taken within this segment, again showing low-grade dysplasia, but I'm not sure, if we took some more biopsies and looked at this further, whether or not this truly is low grade, because the pattern is clearly different, and there's some areas of hypervascularity, etc. So I think from a treatment standpoint, I'm comfortable with RFA in this lower segment. I think that it is okay to treat with RFA down here, but I think for this upper segment, I'm not comfortable right now treating with it. He's only been diagnosed for a short period of time, and so one thing that can happen is if they're not on full doses, double doses of PPI, there can be sort of a more thickening, more sort of roughness, if you will, to the mucosa. And with a better PPI and more prolonged PPI therapy, oftentimes this will smooth out to a certain extent. But I think what I am comfortable doing today is treating this lower segment here with RFA, the circumferential segment. I definitely do not want to treat that area there with RFA. Maybe it'll smooth out over time. My plan now, I'm just seeing this patient for the first time, is to treat this lower segment with the Halo 360 Express because it's circumferential. And then probably either on or off camera, I'm going to rebiopsy these areas up here, and then we'll bring him back better armed to do additional treatments, being EMR, etc. So we're going to start by actually doing mucomist if Leanne has the mucomist. So this is part of the protocol, and the purpose of the mucomist is to get rid of mucus, to get better contact between the RFA probe and the mucosa. I think I deliver this with a spray catheter. This is an Olympus spray catheter. I have this patient intubated, so I'm not so concerned about it. But I don't like the idea of flushing a large volume of mucomist or whatever into the esophagus without a protected airway. And to me, at least, you get some physical disruption with the catheter, in addition to the chemical disruption of the mucus with this spray catheter. So that's my technique. So I'll have Leanne use her muscles and give me a really strong squirt. Go. So I try to achieve this spray that Leanne is doing right now, and I just circumferentially go up and down. And again, I have the patient intubated, so there's a safety measure here. Please don't do this all at once if you don't stop. And so I've done the segment now with the mucomist.
So there's a question, Dr. Hawes, about the order in which this can be done, RFA, then EMR versus EMR followed by RFA?
It's a good point. I think it doesn't matter. You can EMR over segments that you've done RFA because the depth of penetration is such that you can still get a good submucosal lift. I'm just going to suck him out just a little bit here. So I don't think it doesn't matter from that perspective. I think traditionally, to be honest, we typically, if there's clearly a nodular segment, oftentimes we'll do the EMR first and then come back and do the ablation after that. Again, this was low-grade dysplasia, and obviously there may be sampling error. But as I explained in my lecture, it's really about the smoothness versus nodularity. It's not so much about whether this is high-grade or low-grade dysplasia. But today I won't encroach on this upper area here because I still want to see what that happens over time, and I'll biopsy this nodule probably here. But I think traditionally, yeah, you would, I think typically do EMR first and then RFA. The one thing is you can't do both at the same time. I think there is some animal data, at least from Jacques Bergman's group, that there is a perforation rate if you use a balloon and also do a balloon RFA plus EMR. So don't combine the two. But the sequence, I don't think is, it's not etched in stone. Okay, so I've passed a savory guide wire into the antrum. Okay. And then as I indicated, with the balloon catheter, okay, so here is the balloon catheter, and looks like that camera has...
We can elevate the camera a little bit. There we go.
Oh, there we go. Okay. So here is the balloon catheter. Here is the treatment point is right here, if you can zoom in on that. And again, it unfurls. You can see here that this unfurls as you inflate the balloon. So that's the way it works. It unfurls as you inflate the balloon. And it just goes over the Savory wire. So just going to advance it over the Savory wire. Okay, so he's got it. We're using water. Don't use a gel or anything because that can affect the contact. And then I pass this in a twirling fashion. So I rotate it to the right, okay, and that keeps the thing curled up. So don't rotate counterclockwise, rotate clockwise. And then just advance it slowly over the guide wire. And then you pass it basically to about where you think you ought to be. But this is done under endoscopic guidance rather than blindly. Afterwards, now we're going to hook this up. And you match arrow to arrow here and click. And then here is the inflation part here. And just make sure that these connections are tight. So this connection here, twist onto there, and this connection here, twisted onto here. Make sure those are nice and tight so that you don't get any leakage. And then if the camera can rotate a little bit and Bevan gets out of the way just a little bit, you can see that it's on 10 joules. So this is the setting that we use. It's 1 pulse at 10 joules, and then we will wash and scrape. So Bevan's going to hold that for me right now. I'm going to go back with the scope alongside the treatment catheter. Okay, so now here's the endoscopic view.
Dr. Hawes, do you typically use general anesthesia for all your RFA cases?
Yeah, so if I'm doing touch-up, I don't. For my virginal patients, so somebody I've never seen before, it may be an EMR or it may be an RFA. So I prefer a new patient to do general, because then I'm prepared for EMR. I always do general for EMR patients because if you get bleeding, you want to make sure that you protect the esophagus, etc., or the lungs rather. So here's the probe in, and it's obviously in a little bit too far. So I'm going to pull it back. Bevan's going to advance the wire just a little bit just to keep it in place. So again, just to show that the GE junction was at about 46. So I'm going to pull back here, pull back here, pull back here. Okay, so and if you these are Bevan's hands right here, and just watch his hands. He's going to brace this against the bite block. So it's really important that the probe be held in place as it inflates. Here's that nodular area that I want to avoid, and to the left of it, buried by the catheter, is that little nodule that I also don't want to damage. But I think the catheter now, I think, is in a good position. There's one of the biopsy sites there in a distance. There in a distance. So I think that that's a pretty good position to my view, right there. Okay. So now Bevan's going to hold this really, really tight to keep it in place. I'm going to withdraw the scope just a little bit. Keep it right there against the... So I'm going to withdraw just a little bit. Bevan's keeping that sort of tight there. And I'm going to position the tip of the scope right at the top of the balloon, because when the balloon inflates, I'm going to try to look through the balloon to look at the probe to make sure that it fully unfurls. So I'll try to show you that here now. So I think we're in a position. Bevan is holding at the mouth very, very tight, so that the balloon doesn't suck in or suck out, and we're ready to go. You can't see it, but I'll be pushing the white pedal first, and that will inflate the balloon, and then I'll be given a signal from the generator with a blue signal, a blue light, if you will, that will tell me that it's okay to apply the energy. So Bevan's got that really tightly held. I'm going to inflate the balloon now. And I'm going to push up against the balloon. And now I'm getting this auditory signal. It looks like the balloon is completely opened up. And I'll hit the blue pedal, just to hit it, and take your foot off of it. It's delivering the energy. And now it will deflate. And now I'll withdraw the balloon now. I'll withdraw the scope, rather. And we're going to withdraw the balloon. And I like to take it apart. And I think for purposes of showing, I'm just going to remove everything. And again, you want to rotate it clockwise, okay, so that the balloon stays sort of unfurled. Now, what Bevan will do is that he will hook up the balloon, inflate it in order to wash it very well. So he'll wash the catheter to get it nice and clean. And I'm going to go back down, and I oftentimes lose my cap.
So is one of the reasons you took the cap off was so that you could get really close to the balloon so you can look inside during the ablation, Dr. Hawes? If someone was wondering why you took the cap off.
So the cap, I don't want to have the extra size of the cap to go alongside the catheter. Okay. So now I put the cap back on because now I need to wash and scrape.
Dr. Hawes, what do you think about the simplified method of RFA, where there's no cleaning in between, even for circumferential ablation?
So I was going to talk about that in my talk, and I think it's very worthwhile mentioning. The Amsterdam group has done a study with the balloon using, so there's the effect. That's a very, very typical effect for RFA. There's been a nice balloon contact, as you can see. This is a very typical sort of eschar that's there. So that's a nice treatment that extends down to the top of the gastric fold. So I'm actually quite happy with that. So Jacques Bergman, I'm going to just scrape as I talk, if that's okay. So I'm just going to gently use the cap to scrape along the surface here to treat this. So Jacques Bergman, I think, has really led in looking at alternative, more efficient ways to deliver the energy. So could we do it more simply, quicker, but yet get the same or a better effect? And it worked with the focal therapy devices, but it did not work with the balloon-based device. So a recent study, they did 3 different, just as a note here, here's the difference between squamous epithelium and Barrett's. You can see here that the squamous just scrapes away completely, whereas you get this sort of whitish when you have Barrett's. But he did a randomized trial where he did 2 pulses with the balloon catheter, and then that was it. So no washing, no scraping, etc. Then he did, one of the arms was the standard therapy, which is to do 1 pulse, then withdraw it, wash and scrape as I'm doing, and then that's it. And then I think he did one, if I remember right, one where he just did 1 pulse and that was it. And so not a second one and no washing and scraping. And basically he found that the one where he did 2 pulses, without any washing or scraping in between, had some strictures, so that was too aggressive. And the one where he just did 1 pulse, didn't do any washing and scraping and just quit, didn't get rid as much of the Barrett's. So the bottom line is that the current protocol of what I'm doing here, which is 1 pulse, wash and scrape, and then go back in and do another pulse, was the most effective for the balloon. He also did a study to look at the focal devices, and basically one of the arms was to do, with the focal device, what we do is we apply the device to a certain area and give 2 pulses, so 1, 2, and then we withdraw it, wash and scrape, and then come back down and do 2 more. So that's the standard protocol for the focal devices. And the lowdown of his study is that if you did 3 pulses, and that was it, so 3 pulses in one area, go 3 pulses in another area, and then you don't do any washing or scraping, you just do the 3 pulses, that gave equivalent results to as the standard protocol, which is 2 pulses, wash and scrape, and then 2 more pulses. So it needs to be verified. It's one center doing one thing, but I think that we should be, for all of the people out there doing investigations with this, we should be looking for more efficient ways to treat. So if you know anything about bipolar energy or the kind of energy that we're using, it basically, when I do a pulse here, it desiccates the tissue. So all the water is removed from the tissue. What that does is that it means that you can't transmit energy through that dead tissue, that desiccated tissue. And that's why we wash and scrape. If I didn't wash and scrape, then you wouldn't get as efficient on the second go around. So what you want to do is you basically want to get most of the eschar off. And I can afford to wash and scrape here a little bit without any trouble. And now Bevan's got the guide wire ready, so we're going to do another pulse, Dr. Bang. And then that will complete the treatment of the lower 4 centimeters of this patient's Barrett's.
There's an audience member asking about use of acetic acid to improve your visualization.
So acetic acid does not improve. I have no data that it improves RFA treatment. And to my view, it might make it worse just because it causes swelling of the mucosa, and that may alter the thickness, etc. So it's certainly not a part that I'm aware of actually when you're treating somebody. But it has been an effective way to examine the mucosa to detect Barrett's and to look for dysplasia. I don't routinely use it. It's not used very much in the United States, but it's quite popular in Europe for sure. But again, I emphasize this in my talk. The key here is not whether you detect a little bit of low-grade dysplasia versus high-grade dysplasia, etc. If you're committed to treating with RFA, it's about the topography. It's about whether or not this is smooth or not. And because we can effectively treat low-grade dysplasia and we can effectively treat high-grade dysplasia. Okay, so we've passed the probe now again. Because it's quite heavy, I like to pass the probe and then hook it up. And again, make sure your connections are tight so the machine will detect leakage and won't inflate the balloon. Then you give it to your assistant. And again, I'll go back down with my scope, if Bevan lets me in there.
Dr. Hawes, do you typically give antibiotics for this procedure for RFA?
Antibiotics?
Yes.
No. No antibiotics indicated for this procedure. Okay, so the second treatment is a little bit easier. I just need to this is the treatment portion. These sort of copper-colored rings are the treatment portion. So I'm going to advance the scope here a little bit just to get some perspective. Clean my lens here a little bit, suck a little bit. So there is treated area there on the left. So obviously I need to bring the probe back.
And Dr. Hawes, how far distally do you typically go into the stomach for this?
You should, it doesn't hurt anything to go into the stomach. So if you burn the gastric mucosa, it does nothing. I think the more mistake is that they don't go far enough. So I like to bridge at least maybe a centimeter of the upper gastric folds, because the cardia, the lower end of the esophagus and the cardia, are by far and away the most difficult areas with regards to treating Barrett's esophagus. So I think I have the rings there about matching up with my treatment area. You can see the white eschar there and the top of my ring. So I think I'm pretty close to exactly where I was. So I'm going to ask Bevan to brace his hand against the bite block really hard, because I'm going to pull back and I don't want to pull back on the probe. I'm going to position myself against the balloon. I'm going to ask Bevan to hold really, really tight. I'm going to inflate the balloon now. We're again at 10 joules. Inflate the balloon, push my scope against the balloon. Nick Shaheen taught me this. And then when it looks like it's fully inflated and I've got the auditory signal, then I push the blue pedal and that delivers the energy. I don't wash and scrape this area because we're obviously done. And so now I'll just disconnect things.
And Dr. Hawes, just a brief summary of medications you would give this patient for possible pain. Do you give it any topical solutions or pain medicines?
So I think the main thing is to talk to your patients and make sure that they're on double doses of a PPI. That's the most important. About 30% of these patients will have some pain. We typically give a oral solution of Tylenol and codeine, a liquid Tylenol and codeine, if they actually have some pain. And I give it's a Maalox lidocaine solution. And some of my partners, I don't know what you do, Dr. Bang, but Dr. Hassan gives Carafate, dissolves Carafate in water and gives Carafate. So I think that in terms of what's usually given, Carafate, Maalox lidocaine, and pain or pain medication is what's given. I don't know, early on in my experience with RFA, it seems like I gave more pain medication out now. I would be surprised if this guy has much pain. I treated only a 4-centimeter segment in the distal esophagus, and so I think he'll actually do well. But if they have pain, then we'll give them some medications. I have them avoid really hot or really cold things for the next few days, and I ask them to be careful about eating sort of soft foods for the next few days. And then my plan is low-grade dysplasia, so my plan will be to see him back in 3 months to re-examine. If it's high-grade dysplasia, I typically move it up to 2 months because I like to accelerate the treatment if it's high-grade dysplasia.
And then, of course, it will depend on the biopsies of the nodule too. You may bring him a little early if you need to resect.
Exactly.
Region.
Yeah.
Okay,
exactly.
Wonderful. Okay, thank you so much, Dr. Hawes. Now we're going to get ready to go to room 2 with Dr. Varadarajulu so we can show the patient information for the case. Thank you so much, Dr. Hawes. Any final thoughts, Dr. Hawes? No? Okay.
This case is a 75-year-old female with obstructive jaundice and a 20-pound weight loss who underwent an ELCP with placement of a metal stent for a biliary stricture. The brushings and biopsies of the biliary stricture was non-diagnostic. The objectives will be to perform EUS-guided final biopsy of the distal bile duct mass using the Charcot FNB needle. We'll also be learning how to perform tissue sampling with a metal stent in situ in the bile duct, and learn the technique of placing fiducials within the tumour using the Beacon preloaded fiducial system. Now for the literature review. Despite the perceived challenge of performing EUS-guided final biopsy or final aspiration in the presence of a biliary stent, studies have shown that there is no significant difference in diagnostic success when performing EUS-guided final aspiration in the presence or absence of a biliary stent. Also, the type of stent placed, plastic or metal, did not affect the outcome. We're now going to the procedure room with Dr. Varadarajulu.
So, good morning. This is a patient with a pancreatic cancer, as we know. The patient also has symptoms of gastric outlet obstruction. She went on outside a hospital, had a failed tissue diagnosis, but a metal stent was placed. So what I need to do now is to find the mass in the setting of a metal stent, do a biopsy. Here we always believe in rapid on-site evaluation because patients want a diagnosis before they leave. And my second job will be to place a fiducial. So I'm here this morning with my nurse anesthetist Shibli, and my technician is Enrique. Mary is a nurse, and then Conrad is a technician, and Nikki is the radiology tech for this procedure. So what I'm going to do now is show you the normal anatomy. So let's go to EUS image. Let's show EUS on the screen for the audience. So as you can see, I am on the GE junction, and what I see is the left lobe of the left atrium. I advance the scope into the stomach, and here's the liver. So once you see the liver, you do a clockwise start 180 degree, and you'll always generally be on the pancreas. And if you don't see the pancreas, just retract a little bit. And what you find immediately is an anechoic structure here, which is the pancreatic duct with a lot
obstructive debris within it. So that is a dilated pancreatic duct. And then if you gradually pull the scope, move your shoulder to the right side, you find a dilated pancreatic duct all the way down, and then it traces down further. It traces further, and then you're going back to the aorta. So that's the aorta. There's a celiac artery. You advance further into the patient. Let go on the up-down. There again is the pancreatic duct. I don't see a mass. It's always nice to sample from the. It's always nice to sample from the stomach if it is possible. So here's the PD. Here is again the dilated pancreatic duct. I don't see a mass. There is some soft tissue component. And if I turn to the right, I see a little bit of pancreatic duct. It's very ectatic, and then the gland disappears. It's just because of a pancreatic atrophy. So now I'm going to advance my scope from the stomach into the duodenal bulb, and you probably have EUS on your view. I am now on endoscopy in the duodenal bulb. So this patient has symptoms of outlet obstruction, so it's a little bit narrowed there. So I'm going to suck some air. And now EUS, if you have the EUS image, you've got the metal stent here. So I'm going to look down, and this unfortunately happens to be an uncovered stent, so we have to get a diagnosis. So this is the stent, and it terminates into this mass-like lesion. So if I don't see this mass-like lesion, then I will be obliged to advance the scope into the second portion of the duodenum, which in this case is a little blocked because this patient has got tumoral invasion there. And then you see also an anechoic lymph node. So my job here is to do an FNA. Finding a mass in the presence of a metal stent has been considered challenging, but it's usually not difficult. If you torque your scope back and forth, you will generally find a soft tissue area to sample. And this is going to be my target area because this is where I see the duct cut off or the stent cut off. And here is your portal vein, and there's obviously vascular invasion here. So, and that's all ectatic ductal structures. So I'm going to use a 22 gauge sharp core needle. So there are a couple of challenges here. One, you're in the duodenum. So sometimes it's going to be difficult to get this sheath out of the scope and the needle out of the sheath. So this is particularly in a patient with a big pancreatic mass that is causing outlet obstruction. So you pass the needle, up the up-down knob should be all the way down, locked. It has to be very smooth, and then you affix the needle. You open the sheath adjuster until you can see a small portion of the sheath. So that should be pretty good. On endoscopic view, I have a little bit of sheath. So I'm going to lock this. And one other thing you should do before you ram your needle is to make sure the needle comes out. So I'm going to move the needle adjuster. I want to see the needle comes out or not. So there's the needle that comes out very smooth. So if this did not happen, what I will do is I'll go to the stomach, get that needle out as I would see here, and then I will just drag it across the pylorus. There may be some mucosal trauma, but that's okay. So once more, portal vein here. Bile duct there with a metal stent. Portal vein gets somewhat effaced by this mass. I'm going to trace the bile duct into the mass lesion. And then once I have done that, it's not going to be perfect, but with a metal stent, things are a little complicated. See that? There's a mass, and there's a portal vein with a confluence. Turn around a little bit, and that is going to be my window. So once I find this, I'm going to get this needle. Use your elevator a little bit, but move it up. You saw what I did? So I moved the elevator to this direction so that I get a straight shot into the mass. I'm going to advance, push the scope in a little bit, suck air. Okay, don't let it slip out. So if you've got a problem like what I'm having, someone can hold it but not needed. I'm going to keep it right there, and then one sharp jab. I'm in. So Enrique is now going to remove the stylet. So you can go back and forth. 1, 2, 3, 4. Come up. Change your angle. Just don't keep going in the same place, because if you do that, then the specimen gets very bloody and you're not going to. This is called fanning. So you can do whatever you want to do, but just move the direction a tiny bit. So you want to make sure that you're not puncturing that structure there. So that is probably an obstructive duct. Get it out of the view by just moving your shoulder a little bit, and then once more. push the scope into the patient. I'm constantly applying suction like that. So 1, 2, 3, and 4. Retract. And then another soft tissue density area right there. 1, 2, 3, 4, up. Movements back and forth a little bit. Yeah, this is not bad. I'm going to let go down so that I want to come cranially to the mass. And then I'm there 1. Move the shoulder. Never perform a FNA without seeing the tip of the needle. 2, 3, 4, and maybe 1, 5. I'm going to take it out. Lock. And usually, if I'm going to have Conrad, who's our expert cytotechnician, show how he's going to process the specimen using the touch prep technique. So let's move the microscope to the needle to Conrad. Conrad, you want to come here so that we can make minimum adjustments? Okay. There is, you can go from that side, yeah? Yeah. So that is Conrad with his cart. So Enrique is now going to express the sheath, the needle out of the sheath, and then he's going to advance a stylet. So what we do is we don't apply suction because it's going to just splash all over the place. We don't want that. Conrad is now going to just express 1 drop into the slide, and there's tissue. That's it. A lot of tissue. So everything else goes into formalin. See that? And we will, and then they're going to just dip the needle all the way up, and then we will see what we have. Okay. Do a touch prep, Conrad. So Conrad is now moving the specimen on the slide. See, he doesn't smear it. What he does, he just moves it in across the slide. That's it. He does not want to create what is called a crush artifact. So your fingers are closing it, Conrad. Yeah, there you go. Perfect. And then he takes the excess tissue and he just dips everything into formalin. That everything goes off into formalin. And then he's going to dry it. And then he's going to put it in the fixative first. Stays there for approximately 10 seconds maybe. Then it goes into the, what I call the red solution. Stays there for another 10 or 15 dips. So for those of you who don't have a cytotechnician, it's very important to learn this yourself. Because it's important for several reasons. One, if there is sampling error, you can always go back and perform additional passes. You can look under the microscope yourself and you train yourself to look at the slide. You should just be able to differentiate duodenal mucosa or gastric mucosa from a tumor cell. So Conrad is now done with staining. Now he's moving the tissue back into water. And he's just cleaning it, and the slides are ready to go for a wash. In the meantime, yeah, that's a slide. And you can see that material. So just touching gives you that amount of material on the slide to be processed. So he's got 2 slides, and then he's going to go and look under the microscope. In the meantime, I usually perform another pass. I don't wait for anything for a cell block, and then we are done. So let us see if we have, yeah, there is material in cell block, but I might make 1 pass. I'm going to move this table out. And now we can show microscope.
Look, it's locked.
It's locked.
Just
okay,
let me move it. Just
yeah. Okay. The cart is moving out, and then we can now go to microscope for Conrad to show you the slide as I perform my FNA. So 1 more, Enrique. So that is Conrad on the microscope, and he's showing you cells. So that looks like I'm not a cytopathologist. I've been trained a little bit on how to look at these things to see whether I'm there or not. So these cells are clearly abnormal. They're all looking uniformly same, but you can see different morphology with a big nuclear cytoplasmic ratio in some. So that to me tells me that that is a cancer. So that is definitely a malignant cell. Conrad is pointing to fairly atypia, and then he's going to show you those very big giant cells. So when you see those mismatch, then obviously, you are where you need to be. So that is a well-differentiated adenocarcinoma. So the catch here will be, the pathologists are spoiled these days. Those were days when Rose was a diagnostic and they didn't care much about cell block. But since we give them fantastic specimen these days, they insist on a complete diagnosis on cell block. So I'm just performing my second pass because that clearly is a well-differentiated pancreatic cancer. This patient has well-differentiated cancer, and this stent has been there for quite a while now. So sometimes you can have stent-induced changes. We don't want to take chances on this, but to me, the rapid on-site examination is conclusive for adenocarcinoma, probably a well-differentiated. So I'm performing a second pass now, and I'm going to take this specimen, put it into cell block directly because we are in the right place. We have got enough tissue, and I'm now going very quickly to perform fiducial placement on this patient. So the second pass goes into cell block. We don't do any rapid on-site assessment on it. And I am trying to find the best position for a fiducial placement. One might wonder why you need fiducial with a metal stent, but our radiologist tells me that the stent is very long, that when they place the patient on the scanner, the stent does not help them to focus to target their radiation. So they tell me they prefer fiducials to be placed still. So in this particular case, we are using the beacon FNB from Medtronic. So once more, what I am doing is I'm placing this new sheath down into the patient. It's got some fiducials, and transduodenal fiducial placement can always be challenging. It's always challenging. It's difficult. So you can use 19 or 25. It comes in two configurations. In this particular case, I am using a 22. I'm going to suck. And then let's get fluoroscopy. So we need two images on the screen for the audience. One should be the fluoroscopy image, and the second image should be EUS image. So now on EUS, I'm seeing if the sheath will come out, and I'm lucky here. The sheath has come out. That is the stent. So my interest would be to place one here and a second one here, and hopefully a third one if required. So on fluoro, please. And then you're going to go live, and then the needle is deepened, and Enrique is now going to move the hub and deploy the first fiducial. So I can shake it a little bit. I can shake it. Sometimes it gets hung up. There it is. The first one is done. I'm going to use my elevator now. You want to move, if possible, a little direction, and all that you need to do is to change your angle tiny bit by pushing the scope into the patient, torquing your shoulder. Second pass. Fluoro, please. Live, and then the second needle is there, and you can see it's a little further, maybe 2 millimeters away, and Enrique is deploying the second fiducial, and now I'm going to move it back. Can you please? Yeah. So one of the beauty of this system is, take the sheath out, and one of the beauty of this system is we don't need to remove anything. So all that Enrique has to do is to disengage these two fiducials, and then place the second system back into the same sheath. So this saves you money. You don't have to use a new needle for this. You just get a new system with the two other fiducials back. Our radiologists are okay with 2. They tell me that their ideal number is 3. And if they have 3, they're more than happy. So what we will try to do is to just space it out.
Dr. V, a few questions.
Yeah.
Number one, are you considering doing an FMB on the enlarged lymph node that you saw?
I don't think it does not change management in any way. So we don't sample lymph nodes anymore. Nobody asks them for it. So now, see, this can be sometimes a little challenging to get the second needle out. I'm going to lock it in, disengage. Okay, disengage.
And any tips on how to make the mass easier to visualize with the metal stent in place? One of the participants is a little worried about the area being kind of ill-defined and difficult to visualize.
Yeah. So one of the things is imaging. That's where I think the processes come into play. See here, you see the stent on EUS, right? And then all that I do is I turn my shoulder, right? And then you see the mass behind the stent. So this is critical, right? Hypoechoic area. Another way of looking at it is the stent getting narrowed by the mass that you see here. So this, is a biliary stricture. And those are the two techniques that I have. But primarily, you're looking for a uniform anechoic area. So now we are trying to come back with this needle. So this is going to be sometimes challenging because, see that? Did you see what happened? So this was because of excessive pressure that I applied. It's a huge mass that is occluding the duodenum.
Yeah.
And then when I keep pressurizing it through the bulb, sometimes I can accidentally puncture the sheath. So in this case, I have two options. I can quit. I've already done my job. Or what I can do is do something else. I can come back into the stomach, right? I can look at that mass from the neck region, right there, right? And then what I'll do is, I'm going to ask for fluoro for 1 second. I'm going to see where this goes. So it's going to be a long shot. Let me see how far this is going to go. Deepen. Fluoro, please. Again. Yeah, right there. Can we deploy the next fiducial, Enrique? And I'll deploy the third fiducial right into the neck region. Yeah, right there is the third fiducial. I'm going to disengage. That's it, done. Fluoro. So if I want, I can deploy the fourth, not required. So once more, here is the way I'm doing it is pancreatic duct. And then I'm targeting the soft tissue density that's here. If you can't see well, decrease your depth. There you go. And then your mass becomes visible. This is not the most ideal fluoro, please. Not the most ideal spot for fine needle aspiration, but it works for fiducials. Okay, Enrique, let's deploy the last fiducial. And let us see if this will go down. Yeah, that's it. He's deployed 4 fiducials, all separate from each other, and this is done. Any other questions?
Yes, lots of questions. So have you ever had any fiducials being deployed in a vessel or vascular structure? And if so, what do we do?
Not yet.
Okay.
And if it goes vascular, I don't think you need to do anything. This is not brachytherapy markers that is going to spread over and cause a problem. This is not a glue to cause embolization. Usually you will puncture more likely an arterial, like a GDA is the most common thing that you'll puncture. I think it just gets lodged in a vessel wall. Antibiotics is important. That's the only thing I'm concerned. So I always give 1 dose of antibiotic for these patients and nothing else.
And any risk of acute pancreatitis with fiducial placement?
No, infection has been described. To my knowledge, you're going to your solid mass. As long as you don't transect the duct, unlikely.
And there's a question. It says, previously there was an element of anxiety from pathologists about interpreting dysplasia in the context of stent-related histological change. Is that still an issue? No,
dysplasia has a problem with cytology more and less often with histology. So I don't think so. The only challenge is IPMN. Diagnosing cancer on IPMN is always a problem. That is the case where you have to perform 1 or 2 is not going to be enough. You have to perform like 7 or 8 passes to put things together. Apart from that, dysplasia is not an issue, but mostly for solid organs, solid tumors.
And then another question was, have you ever had a fiducial deployed in the main pancreatic duct? And if so,
I don't think I would worry in the setting of a cancer. The duct is already blocked. Okay. Antibiotics and not too worried about it, no. Anything else? Okay. And do you foresee any scope damage with the needle puncturing this? Hopefully not. We are going to examine it when we come out. The sheath was punctured on the outside with a needle, so I don't think that will be a problem. And then I guess this is going to be the last one. Yeah. Have you ever deployed fiducials in prostate cancer? Fiducials in prostate cancer, yes, I have done it once, but not here in Alabama. Oh, in 8 Alabama. Years back. Okay. Yeah, not here. So thank you, and I think you will go for a live transmission to Professor Stavropoulos in Winthrop, where he's going to demonstrate the ProDGI device, and it should be a very exciting demonstration. So thanks for joining us at Orlando this morning, and we go live to New York.
This case will be demonstrated live from Winthrop Hospital in Long Island, New York, by Dr. Stavros Stavropoulos, where he'll be demonstrating endoscopic submucosal dissection using the novel Prodigy traction device. We'll now go live to New York with Dr. Stavropoulos.
Stavros.
Okay, so hi, how are you?
Hey, this is Rob Hawes. Can you hear me?
Yes.
Okay, we can see your slide.
Great. Okay, good morning from New York. And what we'll show is a colony SD that demonstrates the traction device, the Prodigy, and how it can speed up ESD. So this is a 57-year-old man that had some history of hypertension and prostate cancer. And he underwent the diagnostic colonoscopy for hematochezia that showed a 4 to 5 centimeter ascending colon polyp. You can see here a little video of what it looked like, which was a bit concerning because on the right side of it, you can see this pink, non-granular, slightly depressed area. The left one looks granular, but the right side looks like a flat, slightly depressed, non-granular with a irregular pit pattern, probably a Kudo 5I. So there's concern for submucosal, superficially invading submucosal cancer on that flat right side. You can see NBI, I don't know what the quality of the image is there, but you can see at the depressed area, there is not a clear pit pattern. I would call it irregular. And the whole area there is very flat and slightly pseudo-depressed. The left side looks a little better with nodules, but we're focusing on the right side because that's the concerning side. So hence our decision to approach this with ESD.
That was very clear, Stavros, very clear.
Oh, thank you. So now I can show you, the reason I showed you the video is because now it's a little manipulated, because in order to try to show most of the ESD with a traction device, we took the opportunity to do the circumferential incision around the polyp. So we leave only the dissection. The circumferential incision was just a 15-minute circumferential incision. And now we're going to try to do the ESD. Now, the important thing that the Japanese have come up with and have imparted it to our Westerner colleagues is that you have to develop a strategy based on the type of polyp, its location, and its lie. So how does this polyp lie? You can see the liquid denoting gravity is at approximately 7 o'clock here, which means that the left side of the polyp is on the gravity side, and the right side of the polyp up there is the anti-gravity side. So the left side is going to be problematic because it's buried by gravity. The right side is problematic because right now my endoscope is tipped up all the way and I can barely reach. So right now I'm completely 100% on the up dial and I can barely get to this level here. So, so this presents the following problems. Now, how do you use traction? Normally, when the part of the polyp that's on the gravity side is not going to be retracted properly for resection, so you can use the traction on the gravity side to pull that area up. I'm not going to be able to do that because number one, this edge is completely buried. And number two, I would have to deploy the other end of this 2-clip traction device at the top wall, which I cannot reach at all, even with both my dials cranked to the maximum. So we're going to use a different, yes.
Stavros, what scope are you using for this ascending colon ESD?
I'm using a pediatric colonoscope.
Okay.
Some Japanese prefer an adult colonoscope because of its stiffness imparts more of a one-to-one movement. Okay. But generally, a lot of us in the US prefer a pediatric colonoscope. So my strategy would be probably to focus on retracting the top side. Gravity would pull it to the left. I'm going to pull it down towards me to expose the back of the polyp. And that will help me then dissect top to bottom. And hopefully once I get to the gravity side, the traction itself may be enough to not get any problems over there. So the plan is to go top to bottom, but right now, reaching the top, I have my dial to max, and that it will be much more comfortable in my movement if I can drag the top of the polyp down to the middle of my horizon, so I can use the entire range of my dials without struggling to reach the top. So that's the strategy here. Now I have a slide showing the device if you want to see it.
Okay. While you're getting it out, could you just would it help to do this in a retroflex position? And what did you inject into the submucosal space?
Yes. So I don't know what you're seeing right now. All this time I was talking, were you watching my video or were you watching a slide? You're watching the scope, okay.
We see a slide now with the
right, I was going to show you the device and get this out of the way.
Okay.
And then I'll address the question about retroflexion and the injectate. So you can see that, so basically this Medtronic traction device is a nitinol loop attached to a clip. And then the kit comes with a second clip that grabs the nitinol loop and anchors it in a different point to achieve a traction. So I'll show you that. Now, retroflexion. Let me show you the scope guide so you understand what the issue is. So you can see that this polyp is immediately after the hepatic flexure, right there. So so retroflexion is not possible right here in the hepatic flexure because of this. And that is my problem. You could potentially retroflex if you put something more flexible like a gastroscope, but generally the hepatic flexure is terribly difficult to retroflex. As you try to retroflex, the tip basically enters the ascending instead of doing a loop and coming around to the polyp. So the retroflexion here, in the mid-ascending, retroflexion is great, and the Japanese use it extensively. Okay. Here, I wouldn't be able to retroflex, and I tried actually. So I don't have the option of retroflexion. So that's why I'm thinking grabbing from the back of the polyp. See, this is the back incision there, and bringing the top down towards me, and then proceeding from top to bottom would be the best. Now, the injection we used is the Orize gel, which is a very interesting substance because it has the ability to flow through an injection needle easier than Hespan, which is what I used to use, which is a volume expander with lower absorption than saline. So it flows with less force than Hespan, but once it deploys into the tissue, even on a bench top, it becomes a real gel with a lot of viscosity. So it's a great, and it has a blue food dye that gives the appropriate blue color. So that's what we injected. It's very good for difficult ESD because it goes into fibrotic tissue and splays it a bit by its volume and can give you a little microplane to work with. So now we're going to show how the device is used. So I'm going to put down the Medtronic device, the Prodigy, and show how it, and again, distraction in polyps that have a difficult position, it's a bit of a work in progress. If the vector is not the one you want, you can put more devices or rip the anchor off and use a different device. And
so if you misdeploy the anchors,
so that's the
it's relatively simple to remove them and redo it.
Here. So I'm gonna try to grab at the top of the polyp and a little bit on the proximal side of the polyp. Okay. Trying to get rid of it has a little introducer that puts it through the scope. What are you seeing now, actually? Okay, good. So now, okay, so let's see. So I'm keeping the colon deflated in order to try and bring the top of the polyp into my view, because the clip stiffened the scope a little, so I lost some degrees of angulation even more. So here we go. So now it's important when you use any of the clip tractions, it's important not to grab the mucosa leads, because if the clip tears off, it compromises your margin, and you may get a positive margin. You see, you only have like 3-4 millimeters of margin here. So if I grab this mucosa and it rips, and also the mucosa is less structurally robust than the submucosa. So You really want to put it in the submucosa mainly. Now I cannot reach the top again. I don't know if there was a contraction of the colon there. I have to use the lateral dial as well to get these extra degrees of angulation. Okay, open. So I'm going to try to grab the submucosa there, close, which is at the top and slightly on the proximal side of the polyp. See, that's too robust. This is also going to be pulling muscle, so we need to adjust so it's a little more mobile. Open. And let's try again. Can you rotate a little? Oh, no. Okay, okay. Close there. Still a little tight.
Okay.
Open a little. Rotate. Close. Okay. And now there's a colonic contraction. Okay. Now the contraction. See, that's a little more. That hangs a little more, so I think that's good. It gives us a plane to work with. Okay, deploy. So now the way the company envisioned this is then you grab this curved nitinol and put it on the same side as the first anchor. And the nitinol trying to curve is what provides a rolling action that pulls the flap up for dissection. But in the end, I think most of us in most situations are going to use it like just an elastic connector. So now we're going to grab the other end with the second clip that comes in the kit and has a traumatic open. See, the edges of the clip are not serrated. So it's intended to be easier to de-anchor once you're done with the resection and you need to remove the polyp from the colon. So now I'm going to grab the loop there and try to anchor it. Okay. Okay. Close. Open. Close. Okay, so now we're going to try to put it, and then you can experiment with what's the best action. We can do it towards gravity, but I think the best thing would work is to bring it down towards us at 6 o'clock. And then how much tension to put is a bit of a art to it. So I would say you don't want to put too little tension because the more I dissect, the looser it's going to get. So you want to put a good amount of tension. So I would say maybe down here it's going to work. If it's not tense enough, you can always put a second clip to make it, to change the angle slightly. It'll make it even more tense. So I think that may work. Open. So I suck to make the colon wall more pliable. Close. And then do I still have it or what happened there? Yeah, I have it. I think that looks good. Okay, deploy. Okay, let's see what we wrote here. Oh, looks nice. I think. Oh, maybe not. Okay. Well, looks good. See now the polyp is being pulled towards me. Okay. Well, still requires a little bit of skill to get in there.
So Stavros, you could actually grab the loop with another clip, right?
Paralyzed. Maybe I give some glucagon. Okay. Yeah. So the contractility of the colon is one of the factors that makes CSD here a bit on the difficult side. Okay. Any questions?
Can you hear me, Stavros? Stavros?
Huh?
Can you hear me?
No, he wants to stop going out. No, I took it off. It's fine.
No.
I took it off already.
No,
I just took the picture off the screen.
Can they still hear me? Because I don't hear any questions or any comments.
Stavros, I can hear you. Can you hear me?
No, he's contracting again.
Hello?
I was about to start cutting and he's now contracting again. Okay.
You're still live, but I don't hear everyone well. But you're still live. I hear you.
Well, is there a technical problem? Rob, can you hear us?
I can hear you, Stavros. Can you hear me?
No, I cannot hear you.
Oh dear. Okay. Let me get
You're
it.
on the
We can hear.
earpiece.
We
I
can hear
cannot
you very well.
Yeah, but if I cannot hear them, then I cannot respond. Until I re-establish my audio, I think I'll just keep talking. What? Go. Okay.
Can you hear me now, Stavros?
No, it doesn't know. I can hear you through the mic.
Well,
Stavros?
I can hear you. We have connected, of course, through a cell phone, so I can hear you like a participant. Just keep it here, Tarek, so I can hear. So I can hear you, yeah.
You can hear me
You
now,
signed into the
Stavros?
course. That's a workaround. Any comments?
No. One question I had, Stavros. Can you hear me?
Here, yes.
So the question is, if the tension was not tight enough, you could place a second clip on the existing loop.
Yes. I have placed second clips to, and even if the tension is tight, but it happens to be pulling in a direction that you don't like, you can use a second clip to slightly change the direction. At least the ones among you that do ESD, I hope you appreciate how much easier things are by having the submucosa tented like this over here.
It seems like the
Makes
exposure
it
is really,
much
really
easier.
good.
I don't have to use the cap to exert tension. I'm using the hook knife because once you have good traction, you don't need all the safety features of the dual knife. And the hook knife, by having a longer length, can speed up the dissection compared to the dual knife. But these are my two main favorite knives for colon ESD would be the dual and the hook. And for the electrocautery, I'm using the new, I don't know if you can focus the camera, it's the Vio 3, the new iteration of the generator by Irby, which has a great current control based on tissue resistance. By calculating it thousands of times per second, it can adjust the delivery to the tissue impedance. The idea is that you can cut through vascular areas, delivering more or less current and have a relatively bloodless dissection. Mind you, that's not a good way to demonstrate this close. And give me spray. Okay. You can actually use the hook knife close like this to coagulate vessels. But I don't hear any comments.
Very nice exposure.
Oh, okay. Thank you. Open.
I think this is working a bit. Please put it down. Let me try to connect you.
Okay. So there's there's a recent systematic review of the effect of traction on ESD in the esophagus, stomach, and colon, using mainly two clips connected techniques and clip on a string technique, either on dental floss or on suture. And they all show mostly a 20 to 30% reduction in procedure time. And that's all very good, really. It is a bit of a time-consuming procedure.
Stavros, with this technique that you're using, do you change the energy settings when you're coagulating a vessel versus dissection through the submucosa?
With this with a classic generator, you can use Swift, which is a blue pedal, to cut through vessels. You just linger. If you find a vessel, you linger a little more and do it slowly. Another way to do it is use endocut when there's clear submucosa with no vessels, and then use swift or forced coagulation, especially low intensity forced, like around 10 watts, to slowly cook any vessels and avoid the bleed. Obviously, the traditional technique would be to put a coag grasper and do it, but that slows down things. So I think the low intensity forced coagulation is great. Now with a new generator, this current called Precise Sect from the Irving calculates, I think maybe they are showing the generator. They'll try to show you the generator. With a Precise Sect, the new microprocessor, as I said, calculates, I don't know, 20,000 times per second the tissue impedance and changes the current, which is pretty amazing that I had to basically find a microprocessor that can do such intense calculations. But then that means you can just use the same pedal, the blue one with Precise Sect, and if you see a vessel, just slow down and burn in place until it's coagulated, and then move on and continue cutting, all with the same current. And so far, we've had it for a month or two, and it's working very well that way. Now, I don't know if you had some experience with the Vio 3, that new generator. I think it just has been in Europe for years, but it just became FDA approved here a few months ago.
Yeah, it's just coming. We've
lost the audio
demonstrated
again,
a little
so
bit.
you have to come close so I can.
Stavros, there's a question about the depth of your dissection. Do you try to hover very close to the mucosa, or do you just go into the middle of the submucosa? What's your technique for colonic ESD in terms of the depth of your dissection?
Yeah, the idea is to stay in the middle of the submucosa. You don't want a positive margin on a cancer, but also you don't want to expose muscle if you can. In some organs, like the stomach, I tend to go near the muscle because, number one, the muscle is thick and safe, and usually the stomach lesions are cancer, as are the esophageal ones. So there, I think you should err on the side of the mucosa, of the muscle. In the duodenum, any exposed muscle is a disaster because the digestive enzymes will cause a delayed perforation with a significant probability. In the duodenum, you do not want to see muscle fibers anywhere. And then in the colon, with a vessel there, right? I approached it delicately and then stayed next to it and coagulate it in place. And once it's done, then I move on. Now the colon, you can expose muscle. And Michael Burke has this classification where the level 1 muscle exposure, the grade 1, is what he calls the whale teeth, where you see the bundles of the circular muscle fibers exposed but not injured. And then grade 2 is a bit of a heat injury. Grade 3 is deep injury, and then 4 and 5 is perforation with or without soilage. So generally, I don't like to see significant amount of muscle, like the whale teeth, even in the colon. In the esophagus, if you want to inject steroids after the ESD, which is important to prevent strictures in the esophagus, again, leaving a layer of submucosa over the muscle allows you to inject steroids without risk of injury to the muscle or potential for delayed perforation. So generally, other than the stomach, you should really try to mostly avoid exposing muscle in any way. Yes, that was a pretty wordy response to that.
It doesn't look like you've encountered too much fibrosis. Is that correct?
That is correct. That will be on the Japanese classification. I would call this an F0. They have F0, F1 is mild, stringy, whitish submucosa, F2 is very dense, difficult to penetrate scar. So this would be a nice F0. The referring physician, to his credit, didn't even biopsy the lesion. It's one of the enlightened ones.
I'm pleasantly surprised, Stavros, that with this one clip placement, you continue to get really good exposure.
Oh, disconnected again. Come closer. Yeah, my AirPods on the ear is a poor way to do the audio. Lesson learned. So yeah, the traction is as well as one can expect. Yeah, I'm very impressed myself. Sometimes traction works a little bit, sometimes it doesn't work so well, and you need to readjust it. But overall, as I said, most studies saw a 20 to 30% procedure time reduction, which is, amazingly helpful for ESD. Now, I can tell you what else works, which I'm using here. I forgot to mention it. I showed you on the scope guide that it's a difficult location in the hepatic flexure. Actually, in the Japanese difficulty scores and assessments, flexure location is one of the factors of difficulty. The others too, but the flexures, the sigmoid colon, are difficult areas. So here we're using the dilumen, which is a double balloon. It's a sheath with two balloons that provide stability to the scope, particularly in flexures such as this one. I mean, I have had a lot more trouble with non-one-to-one seesaw movement, going in, coming out without the dilumen, which we use extensively. We've shown in a case control study that dilumen, we compared, I think, about 70 dilumens to 100 conventional that were matched for difficulty factors, including location in flexures, fibrosis. So it showed 25% 25% procedure time reduction. Close. Spray. See, I didn't do it patiently, and there was some bleeding. but you can use the knife with some spray coagulation to control it.
Open.
Okay, open. Any other comment?
No, I'm just, I'm really impressed with this exposure. I mean, I'm pleased that there isn't a lot of fibrosis, but I'm really impressed with how good an exposure. I think it's also partly due to the fact that you've gone from the sort of anti-gravity side to the gravity side. Is that correct?
That is correct. You use the traction here to modify the gravity vector and bring the polyp towards us and lower, so the scope can dissect the top with a straight tip as opposed to a all the way angulated up, which would have made our movement back and forth, what I'm doing now, a lot more difficult.
Yeah. Stavros, do you use glucagon during these ESDs to limit the colonic motility?
Yes, absolutely. We use glucagon, we use Robinol. Yeah, if some colons have increased motility.
I'm also impressed that you've done one injection and you haven't had to inject any more for the ORISE.
Yes, the ORISE has this effect. Routinely, when I get to the other end of the resection, the distal one to the scope, I find a nice big injection like it was freshly injected. Now it's gonna get a little trickier because we got to the all the way to the gravity end. Oh, close. I have a bit of a bleeder here. Okay, let's try to tamponade with a cap and see what we're doing.
When you're controlling a bleeder, Stavros, do you ever just put the catheter on the spot and see if the bleeding stops before you apply the energy?
Yes, this is a great trick. Because see now, if you are tamponading it,
Yes.
you decrease the heat sink.
Yeah, exactly.
Like good old-fashioned hemostasis. This doesn't want to stop. I'm gonna have to use a coag grasper soon. Slowing down, but it's a persistent one. Well, what time before we have to use the grasper? Yeah, give the grasper. This is annoying. If you do too much spray coagulation, you could end up the hole in the specimen or a hole in the muscle. So here I'm gonna use, what is this? I meant a hot forceps. Really? Give me the hot forceps. Yeah, when I'm saying coag grasper, most times I mean a hot forceps because it's less expensive and it's more forgiving. It's easier to rotate. It allows more space in the channel for suction. And it has those cupped arms that can grab. If you can't see the exact place of bleeding, they can grab all around it and be able to get it.
These are just biopsy, hot biopsy forceps, is that what it is?
Yes.
Okay.
What helps is to put a marker of how much you should insert it. Because now I have to go slow to avoid poking it right through the muscle. I have to go centimeter by centimeter. Oh, there it is. Open. Close. Now you check and see if the bleeding stops. And if it stops, you're in a good place. So you can, okay, I lost.
Now you tent away, you pull toward the scope.
Let's see what they did here. I need to, we're changing the settings now. Let's go.
Hemostasis now.
Okay, do it.
No,
That's one of the disadvantages of the Vio 3. Every time we switch from a one monopolar to another, we get this, you know, situation.
No.
Come on, really.
Hemostasis. If you put no.
No.
What kind of energy are you trying to deliver? Is this soft coag or?
I mean, on the traditional Vio is the soft coag effect 580 watts.
Right.
I think that's the one current that most operators in the world can agree on. Yeah, that now I'm being sabotaged. I'm getting 0.7 on the Vio 3, which is how many watts? 7 watts. So not surprisingly, it's a placebo intervention. So let's go to 40 watts. The numbers on the Vio 3 are very different. You get some decimal number. So we'll figure it out in the end. But you know, the important thing is to look at the watts, and then that will give you some equivalence.
And in terms of endoscopically, are you looking for this bubbling? Is that what your effect is looking for?
Yeah, nice little cooking, low temperature cooking is what you want. So the bubbling is good. Okay, so now let's clean some of the dirty liquid. Okay, so let's see where we are. So we are down to the bitter end. And the question is, we lost quite a bit of our tension because now we have like 3 or 4 centimeters dissected. So it's always the question, should you try to tighten the tension or keep going? I think what I'm going to do here is inject some extra Orize and go for it. Because I don't think there's more than 10, 15 millimeters left. So I'm just going to inject here. The tension
seems like you've still got good exposure.
Yep. Okay, so let's inject, open. Right there, inject. Nice. Stop. All right. There, inject. Nice. And then maybe in here, inject. Okay. Here, inject. And right next to that vessel, inject. A little bit down here, inject.
Caliber needle do you use to inject the Orize?
Yeah, this I think it's a 25. What needle is this?
25.
It's a 25, which just goes to show you how easy it is to inject.
Yeah.
So now this lift will give us safety. Because as the bowel turns now, the muscle will come on fast. Just trying to bleed a little here. Okay. Open. And then I don't bother with adjusting the hook knife too much. As long as it, close. That's an artery there, great. It was hidden. See, this part that is folded up doesn't give us good visibility of the vessels. I have to go very superficially open and use the blue pedal. Now I'm up to spray, which is even more coagulating than the precise sec. So you see, I'm getting a little difficulty here because I'm at the bottom. I'm in the fluid.
So you're in the fluid, right? Yeah.
Yeah, the gravity side is the difficult one. When there is a choice, you should start ESD on that side.
Would it help to rotate the patient at this point, Stavros?
Yeah, probably. I just find the thought disturbing. It's a big American patient anesthesia. I'd rather keep trying like this.
I must admit, I sort of agree with you. When I go internationally, I see them rolling the patients all over the place and doing right lateral and this and that. It seems to be more burdensome in our practice.
Okay, imagine if you sometimes you do it, and I do it out of desperation sometimes, and then you realize that the new position is not helping.
Yeah.
And then you need to turn them back. Very annoying. Particularly in the stomach, you can miscalculate what vector you need when you rotate them. Close. This area is very vascular.
Are there parts of the colon that are more vascular than others, Stavros?
Really, the main one is the rectum.
Okay.
Rectum is quite vascular. Here in the right colon, it's a bit of the lack of a draw. I guess it depends on whether you're on the mesenteric side or not, which I'm not sure how we can figure out. Open. Although thinking about it, gravity, he's on left decubitus and it's in the ascending colon. So that means gravity should be, yeah, if gravity is at 7, maybe the mesenteric side would be to, 4 o'clock or something? So it makes sense. So this could be the mesenteric side right here.
Okay.
We have to go a little slower through the vessels. Now there's the fluid. Okay. Okay, let's start from the top. You see, this side is less vascular.
There's a question from the audience, Stavros, about using, why don't you use the nano knife? Does that have any advantage for you?
The IT Nano, yeah. I used it 2 years back. I just didn't agree with me. I think I mean, the reason I am down to the hook knife is the precision and the ability to hook things away from the muscle. The IT Nano gives all this up for the sake of safety, or alleged safety. It's very irritating to be hampered in your resection by an insulated tip. I've seen, I mean, the most impressive demonstration of the insulated tip, and that's where I use it, is on retroflexed gastric gastric lesion resections in the cardia, where you get just the right angle to sweep down from left and from right towards the middle of the lesion and resect it very fast. Particularly if you exert traction also with a loop and clip. But in the colon, it's just such a nasty situation with usually manipulated lesions, fibrosis. Having an insulated tip dragging into the tissue doesn't make for a precise section. Okay. It's getting very mobile now. That means the final attachment is... Come on. I guess I got a little excited there. Okay, give me the forceps quickly. Yeah, this is an arterial bleed. If we muck around with a knife, we'll be under blood and not be able to see anything. Hold the tension on the scope. You have to act fast. Gravity side is difficult.
It's very difficult, yeah.
You put a mark.
Right here, all the way up. About here.
Better be accurate or I'm gonna do a peritoneal entry with a forceps.
Okay, you can start
Okay.
now.
Now where is it?
You got it, you got it.
Open. Close. Very good. Now open. This is gonna delay us majorly here. I'm bleeding under the close. Maybe not. Better lucky than smart. Okay, there we go. I'm not seeing a lot of bubbling here. What are you doing? Sabotage. What's going on? I'm not seeing anything. So higher would be nice if it was working. Yeah. This is sabotage. It's not working, so I don't know what's going on. Now I lost my window of opportunity here. Really? I can't see. Can't see.
Do you think you have partial control over the vessel? Is this?
Yes, I'm next to it. And that works. If you have good cautery, it works well.
Right.
You anchor it next to it. If you don't have it, you move over while holding your anchor, and you get it. If you have cautery, though. If you don't have cautery, you lose the pressure, Let me try again. I'm not delivering any energy at all. Not delivering any energy at all. Come on. Okay, well, what's going to happen now? Oh, thank God the patient is not exsanguinating. Oh, I'll try something else. I don't think it's delivering anything. I don't think it's delivering anything. Go up on the water to do something. Go up on the water. I'm losing control here. Losing control. What? It's not doing. It's not doing it. It's not doing anything.
At least the bleeding is slowing down.
Well, not really.
Much
I'm
better
just
exposure there,
tamponading it.
Stavros.
Oh, there you go.
Oh, there we go.
No, it takes two. Energy delivery is. I don't want to let go and reposition because I'm gonna lose visibility. Right now, the anchor of the forceps is what holding me near the bleeding side. The minute I let go, I'll be under a sea of blood. So I'm just holding on, trying to suck the excess fluid. That's where it helps to have the forceps instead of the coag grasper. The coag grasper takes a lot of the channel. Well, it takes more than the forceps. So trying to suck the blood around the forceps, not as easy. I mean, around the grasper is not as easy as around the forceps.
I think it's an important point to make. When you get this kind of bleeding, if you don't have any suction, there's no room in the suction channel, it just makes things that much more difficult.
Yeah, I might have to let go because it's not working. Whoa, 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 whoa. Okay, I'll start to inflate. This is terrible. Give me something else. Give me spray. I don't know. Give me something.
I know this is difficult for you and the team, Stavros, but there is a lot of learning for the rest of us here. One of the things that strikes me is just the need for patience, that you didn't
open.
You haven't panicked. You've stayed, tried to maintain a good visualization. It's really important points for everybody in the audience when with this kind of bleeding.
Well, the audience must have figured out by now I'm a little short on patience. But I do my best. I do my best. But I'm patient as far as Greeks go, I think. But not as far as Japanese go. Anyway, I think the Bio 3, that's the only really thing. When you switch from one accessory to the other, sometimes you need to fumble around to make it accept a new accessory. But this is just software issue that I'm sure that will be rapidly resolved. Now, I'm gonna try to suck the cloth off because it's gonna be right on the final part we are resecting. So what worked is using spray coagulation. That's a very aggressive current. But if you just do a few pulses, even with a hot forceps, it works. In the colon, another technique is underwater ESD, particularly on polyps that are on the gravity side. You can basically float them by using the underwater technique. But in that technique, getting a bleed means you have to empty all the water and then refill. So bleeds there are even more time consuming. Now, here he bled quite a bit, so it's a bit time consuming cleaning the clot. Well, let's give some air and see where we are. Let's see this, the Japanese found this on the learning curve of trainees. What really stops them in their tracks is uncontrolled bleeding. And these are where really the only times that the preceptor had to take the scope when the Chinese trained the trainees in ESD. Is this kind of situation where there's bleeding that is difficult to control. And it's a bit time consuming. We controlled it. But now we have to suck the clot, clean the liquid. Okay, some of the clots are too big to suck. Okay, well, let's go see if we can see anything despite the clot. See, the traction has loosened substantial now. Sometimes it detaches. I don't think that's the case here. See, the two clips are together. The nitinol has curved up, and there are keys in there. Okay, we can maybe try to continue without cleaning all the cloth. If that's possible. Not sure. Okay. Well, this is exactly the point where you would switch to another room. Let's see what's in the next room.
Yes.
But with this single case, it's good for the audience because you can see all the little ugly details.
I mean, I think, as I mentioned earlier, Stavros, it is a benefit. Most of us, because of the live courses and switching around, we don't get to see the different things that you go through when you encounter things like bleeding or etc. It seems like it is going to be a challenge to work now in a field that's not ideal in terms of blood clot and so forth.
Yeah, I mean, normally I would take the time to clean everything. But number one, I want to show you the end, and I'm hoping that I'm close enough to the end that I can just avoid the cleaning. I may be wrong on that. The thing is very mobile, so I think we're very close to the end. It's just unfortunate that we hit that vessel. Okay, let's see. Let's inflate the colon to try and achieve the maximum tension, or whatever tension is left, and see if we can plow through. Okay, let's see. We have a little bit of a window here. So keep insuflating to bring the two walls as far as possible and re-establish traction. A much more ugly field. Okay, open. I'm gonna focus on spray now because I've had it with all those vessels. Spray is a bit of a dangerous current because it has very high voltage, so it can do unpredictable things. But it's very hemostatic.
Would you be wise to inject a little bit more, do you think, or no?
Yes, I will do it as soon as I can see better. I don't want to blindly go into the blood clot and try to inject in case I inject the wrong thing, like another artery. Oh, what is that? Really very vascular here. It's not gonna leave us alone with the bleeding. Okay. Even with spray coagulation, he's trying to bleed. Should I close? Yes. Okay, open.
The local it is after custody. You witnessed like more bleeding with malignant bleeding more than benign, or doesn't really do anything with the nature of the lesion?
I said, do you see more bleeding with what?
Do you see
Can you hear me, Stavros?
Take it.
Stavros?
Yes, I think I
sorry.
ran out of battery.
Okay, I lost you here for a minute.
Hello?
I can hear you now, Stavros. Can you hear me?
Okay, can you hear me now?
Yeah, I can hear you now, Stavros.
Okay, so I was working through that fat there.
Yes.
Which is, see the charring. See, the problem with the fat is it cooks with spray. It has vessels. It doesn't cut as well as submucosa because it's an insulator. And then it tends to vaporize and stain the lens of the scope. So if you can avoid the fat, it's better. The resections of the ileocecal valve is particularly a bit of an issue.
It's difficult because of the fat, yeah.
Now, I don't know.
Take it out.
Okay, let's see what's in the bottom here. That's the final attachment. Right? Trying to escape. Open.
Okay.
Oh, I can't see it. Okay, now I may have to inject. I see a little bit of submucosa over here. Yeah, I mean, it's 90% resected, but as expected, the gravity side is torture.
It's the most difficult, yeah.
And this fat here, with the vessels in it, has created this coagulated tissue. So I'm going to inject under it.
Yeah.
Inject. Stop. Now on this side, I'm not sure where to go. Inject. Stop. I have to inject around this black mess with the vessels in it. Inject. Okay. Inject. Okay. Inject.
what the base of the device is.
I don't think we can inject anymore. Inject. Looks like we have to cut this black mesh. And looks like it has still live vessels in there. Let's see how it's gonna work. You got to hook it from
On the bottom?
from the bottom.
Got it.
Hook it from the bottom. Open. Okay. What are you doing? There you go. Perfect. I'm gonna use spray now and cross the fingers.
Can you lift it up away from the?
There you go. Yeah, lifted it away from that muscle fold. So we're getting through it. All right. What do we have here? Let's go underwater. Yeah, see now a little bit of traction some different way would have helped us.
I was just going to ask that question, whether or not to take that flap and clip it in a certain direction, would it help?
Yes, the question is which way.
Which direction? Yeah.
And I think it's starting to bleed again. Well, you can go, the other thing you can do is go from the back and see how much of it is attached. We just have to suck the fluid out. See, all we need is the back of it. I could try to change the traction and make it go to the right a little.
That's what I was
the
thinking.
Second clip, and see if that helps me. And most of it is resected. It's really annoying that this spinal part is giving us this trouble. Now I'm behind it. It's so mobile. See, right here is what we need is this back end right here. This final attachment. Question is, can we change the traction vector or should we just go forward and use the cap to cut this back end here? Difficult decision. See, I have a little bit of a window here. Let's inject first. See, that's the posterior incision that I'm stretching with a cap.
That's the, okay. So I can see the incision there. Yeah. That's pretty good exposure right there, except you're working perpendicular, aren't you, a little bit?
Sorry, I lost the audio there for a second.
Oh.
Okay, so I'm just gonna try to inject this final attachment and use my cap to sneak in there. Okay, let me go underneath, right there. Again, there's fat here. So our injection is not gonna be so crisp. Open. Inject. Okay, stop. And check. Go.
Oh, man.
Okay, stop. Inject. Nice, go. And move it up here. Inject. Okay. Okay, let's see now. Let's cut here. So I'm gonna try to detach it from front to back if it's even possible. If I can use the cap to put tension on this side. And if it stops bleeding for a little while. Okay. Are you ready? Okay, open. Yes. Okay. Okay, I'm putting tension with a cap now. Very unstable. Ella, is she paralyzed?
Yes.
Okay.
I think one of the things that I'm appreciating a lot, Stavros, is the exposure now is quite difficult with the charring and everything. So I hope that the audience takes away from this really that these cases can be really difficult. And it seems to me that you're almost using the Jedi experience to figure out where you're dissecting.
Yeah, at this point, the planes require some experience.
Yeah.
To figure out and not make a perforation or cut into the specimen or anything. But you don't start with this lesion. As on the hepatic flexure, you should start on rectal ones and distal gastric ones. But then the mid-ascending colon would be the next one. People think, oh, the right colon is difficult. Well, not all right colon is difficult. The mid-ascending is pretty manageable, particularly for 3 centimeter lesions. Okay, now the question is, should we put another traction device in some weird way to help us? Because it's not very easy to use the cap here.
Stavros, I think we're going to stay and watch you put the traction device and then maybe let you finish quietly in your own sort of unit without us bothering you.
Well, it's no bother if you want to stay. It may just be painful to you, but I don't mind.
We've enjoyed this a lot.
You enjoy my pain, okay. So let's see. Let's see if there's some place we can put another traction device. So this is the back end here.
Okay.
That's just all that's holding it.
And really, that's all that's holding it. It's just too bad it's a clump of fat. I cannot get the crisp cut on, but this is really the back.
Because it didn't connect anyway.
Well, this is it here.
Why can't we just cut it?
Let's just cut through it. Let's just cut through it. And there's only a 10mm attachment there. All right, that's it.
Is that the back edge of your circumferential
Yes.
cut right there? Okay.
That's all that's left. It's just not clean submucosa. It's just these clumps of fat that don't make for a nice crisp plane. So keep it up. Keep the hook up. Kelvin up. Okay, stop, stop. Not towards the muscle. There. Okay.
Couldn't see.
No more Mr. Nice Guy. Okay. Flopping around. Okay, there you go, there you go. Okay. I could theoretically snare it now.
I was going to ask that a little bit earlier about whether that would be a strategy that you could employ.
Yeah, it's just this final attachment. But we're almost done, I think. This is it, right? Okay. We're down to the last 5mm, I think. Okay. That's it.
That's it, isn't it?
Okay. Yeah. Final little hinge. Still trying to read. Okay. Which other one? No, it's fine.
Every time it goes into the muscle and the other way. Yeah.
What's left? Wait. Come on. Okay, last one. Okay, that's it.
Stavros, kudos, man. That was absolutely
that
fantastic.
final one here, you can tell from the black,
Yeah.
the part of the vessels here was the problem. But
Yeah.
see, the muscle is not injured.
Yeah.
And it's all resected on block.
Beautiful.
And that's it. So what I'm
Stavros,
gonna do now is I'm gonna suture it. But I hope, you know, that was sufficient for your presentation.
All right.
I don't know if you want to see the final piece.
I think we have to go, Stavros. So
Okay.
we're going to allow you to suture that and in your own peace and quiet. But I really want to thank you and your team for doing this for us, as you're a master technician and your team is fantastic. We really appreciate this chance to see the benefit of ESD.
Thank you. It was a pleasure. Thank you.
For the audience, I want to thank all of you for joining us this morning. I hope that it's been a good educational event for you and a good use of your time. We would really appreciate it if you would give us feedback. Please feel free to email me or Shyam or whoever. We'd be delighted to get feedback. Please let us know what we did well and what we did poorly, and we'll make for better webinars in the future. So again, thank you all, and everybody have a good day. Stavros, be safe.
Thank you.
And be well. Thank you again.
Thank you. Bye-bye.
Okay. Cheers, everybody.
Cheers. Cheers. Cheers.